All right, let's dive into a super high-yield explainer on iron deficiency anemia. We are going to cut right to the chase, focusing on the key facts, the buzzwords, and all the clinical pearls that you absolutely have to know for your exams and, for real life. Let's get right into it. So let's kick things off with a big one. Think about all the things that can cause anemia. What is the single most common cause? Not just here, but across the entire globe. Yep, you got it. Iron deficiency. It is by a huge margin the most common reason people are anemic worldwide. And that's exactly why we're giving it this deep dive today. So here's how we're going to break this down. First, we'll nail down the basics of diagnosis. Then we'll play detective and solve the missing iron mystery. After that, we'll look at the classic clues and strange cravings you might see. Then it's off to the lab to crack the code on the blood work. And finally, we'll talk about how to get those iron stores back where they need to be. Okay, first things first. Let's establish the absolute core principles of making this diagnosis. You can really think of this as the foundational triad for understanding iron deficiency anemia, or IDA. This three-step framework is everything. Seriously, it's your whole workup in a nutshell. Step 1, you check the labs and find a low serum ferritin. That tells you the body's iron savings account is empty. Step 2, you have to assume it's caused by bleeding until you can prove it's not. And step 3, the final confirmation is when you give them iron and they get better. It's a therapeutic diagnosis. All right, so now we get to play detective. We know the patient is iron deficient, but the real question is, why? Where did all the iron go? We have to figure it out. So the reasons usually fall into a couple of big categories. The number one culprit, by far, is chronic blood loss. That could be from the GI tract, which is always a red flag, or from heavy menstrual bleeding. Next up, you could have problems with absorption. Think about conditions like celiac disease or an H. pylori infection messing with the stomach. And finally, sometimes the body just needs more iron than it's getting, like during pregnancy, or if the diet is just plain deficient, or if someone donates blood a lot. Okay, I really need to hammer this point home because it's that important. In an adult, especially we're talking a man or a postmenopausal woman, if you find iron deficiency anemia, you must assume it's from a GI bleed. This isn't just a guideline, it's a critical rule. You have to go looking for a source of bleeding because you could be missing something very serious. Okay, let's move on to what this actually looks like in a patient. This is where we get into the classic clues and those high-yield buzzwords that you just know are going to show up on your exam. Pay attention to these. So to start, you've got the symptoms you'd see with pretty much any anemia. Your patient is going to feel wiped out all the time. Their heart might be racing, they might feel palpitations, and they get winded just going up a flight of stairs. All of this makes sense, right? There's just not enough oxygen getting delivered to the tissues. Now for the really specific clues. A huge buzzword here is pica. This is a bizarre craving for things with no nutritional value. The absolute classic example is pagophagia, this compulsive need to chew on ice. If a patient tells you they're going through bags of ice a day, you better be thinking iron deficiency. And here's one you can actually see on a physical exam. Koilonychia, or what we call spoon nails. This happens in really severe, long-standing cases. The nails get brittle, they lose their normal curve, and they actually become concave, kind of like a spoon. It's a very specific physical sign. And for a classic textbook syndrome, you've got Plummer-Vinson. It's a specific triad of 3 things. 1, dysphagia, which means trouble swallowing. 2, that trouble is caused by these little membranes in the esophagus called esophageal webs. And 3, it all happens in the setting of iron deficiency anemia. Super rare, but a classic board question. Okay, so we have our suspicions from the history and physical. Now it's time to go to the lab to get the definitive proof. This is how we confirm what's going on, and just as importantly, how we rule out other things that can look a lot like IDA. It's really important to remember that iron deficiency is a process, right? It doesn't just happen all at once. First, the body uses up its stored iron, so your serum ferritin level drops. Then you start to see the hemoglobin fall, but the red blood cells are still normal-sized. That's a normocytic anemia. It's only in the final classic stage that the bone marrow just can't keep up anymore, and it starts making these small, pale cells. That's your microcytic hypochromic anemia. Pay attention here because this table is pure gold for your exams. These are the big 3 on your differential for microcytic anemia. Look at the key differences. In IDA, the ferritin is low, the tank is empty. And the body is screaming for iron, so the total iron binding capacity, or TIBC, is high. Now look at anemia of chronic disease. The ferritin is actually normal or high because iron is trapped in storage. And thalassemia, that's totally different. The iron studies are usually fine, and the big giveaway is often a super high red blood cell count. Knowing this table is crucial. So what if we actually peek at the red blood cells under a microscope? Well, in really bad IDA, the peripheral smear can look pretty wild. You'll see what the books call severely hypochromic cells, meaning they look really pale. But you also see these strange shapes, like target cells, and these weirdly long, thin cells that look like pencils or cigars. And here's another little lab pearl for you. Don't be surprised if the platelet count is high. It's something called reactive thrombocytosis. It's pretty common in iron deficiency, and sometimes the count can climb pretty high, though usually not over 800,000. So we've figured out the why, and we've confirmed it with labs. The final piece of the puzzle is, of course, how do we fix it? Let's talk about management. When it comes to treatment, it's actually pretty straightforward. You've got two main options, oral iron or parenteral, which is IV iron. For almost everyone, we're going to start with oral iron pills. We only bring out the big guns, the IV iron, if someone just can't tolerate the pills, if they have a condition that prevents them from absorbing it, or if they're losing blood so fast that oral iron can't possibly keep up. The go-to medication is ferrous sulfate, 325 milligrams. But here's a key clinical point. We used to tell people to take it 3 times a day, but now we know that dosing once a day or even every other day can actually increase absorption and is way easier on the stomach. But what happens if you're giving them iron and nothing? Their numbers aren't improving. Well, you've got to have a differential for that too. The number one reason by far is that the patient just isn't taking the pills. But if they swear they are, you need to think, was my diagnosis wrong? Maybe this is actually thalassemia. Or is there an absorption problem I missed, like celiac disease? Or are they just bleeding faster than I can replace the iron? And please, please, please remember this. This is a super important point for management. Your job isn't done when the hemoglobin gets back to normal. You have to keep them on iron for another 3 to 6 months after that. Why? Because you're not just fixing the anemia, you're refilling the entire iron storage tank, that ferritin, so they don't just become anemic again in a few months. All right, let's wrap this up with one final thought question to really cement this in your brain. You have a patient with confirmed IDA. They swear they're taking their iron pills every single day, but their labs just aren't budging. What's the number one cause of malabsorption that should be screaming at you from the top of your differential? It's a key connection to keep in mind. Thanks so much for tuning in.